Very good question, because one of the most important things of having a safe pregnancy when you have cardiovascular disease is a very thorough assessment, not only of the structure, so we're clear of what the actual cardiac problem is, but the function of the patient too, both objective and subjective assessment. Importantly, that will help assess the risk. Are they compensated? And also allow us to maximize or optimize them, or treat them if they need any surgical or percutaneous treatment. And so making sure they're seen, they have a discussion, a physical exam. They may need imaging such as an echo or MRI to further ascertain the issue, particularly for complex congenital disease. And then not only subjectively what New York Heart Association functional class they're in, which predicts risk, but sometimes, say, for example, with a coronary patient, you might want to do a stress test to assess if they have any ischemia. Excellent question, again, and it depends on the actual problem. So for example, valvular heart disease, if the regurgitant lesions and they have a normal ventricle and normal functional status, tend to do well. So that volume lesion is well tolerated. On the other hand, stenotic lesions such as mitral stenosis, aortic stenosis, may be well tolerated if they don't have pulmonary hypertension and their ventricle's normal, unless it's severe or symptomatic. Then the risks of heart failure go up. And so assessing those prior. In the complex congenital patients, again, that's a very long list, and I would suggest we usually look at the modified World Heart Association functional Heart Association classification 1, 2, 3, and 4, and that's in the European guidelines. And for example, those that are in the class 4 from the World Heart Association have a very high risk of both mortality and morbidity. For example, Eisenmenger's and severe pulmonary hypertension, and you would counsel against pregnancy and recommend termination should they become pregnant. So for women in general, that's a good point. So in the non-pregnant population we're talking about. So as you know, heart failure with preserved ejection fraction is quite common, particularly in the elderly, and up to 50% of women that have heart failure have it due to preserved ejection fraction rather than reduced ejection fraction, for a number of confounding factors, perhaps because of more hypertension, and more risk factors, but also because it's they tend to live longer and it occurs in the elderly. The treatment strategies should not differ between men and women. As you know, we haven't found a medication that changes mortality per se as we have in reduced ejection fraction for either gender. But being careful to assess functional capacity, because if we think about the primary problem with these patients, they're on the steep part of the pressure volume curve, and their pulmonary pressures and their dyspnea becomes markedly worse with a little bit of exercise. And it depends on the etiology usually. We know that women with coronary disease tend to present later. They tend to present with more comorbidity. When we look at or adjust for both age and comorbidity, there doesn't appear to be a gender difference, but that does mean that the women in general will have more comorbidity that needs to be taken care of. There does seem to be some gender difference around heart failure in particular, because we don't have as many women included in the heart failure trials to look at sub-analysis per se, but importantly, we still are not treating women any differently, say for example with ARNI or ICDs. We still use the same criteria in men and women. So I think that's an important take-home message. Though we didn't do a good job of recruiting enough women into trials, we still, without further data, would treat them the same by the same guidelines.